Well, first of all, could you just introduce yourself for us?
Yeah, I'm Matt Mekkes. I'm the program director for the Occupational Therapy Assisting Program here at Grand Rapids Community College.
Great. Thanks for helping us out today.
Glad to help.
The first question I have for you is, could you just explain to us why occupational therapy is called occupational therapy?
Yeah, we actually spent a lot of time in some of our early classes talking about that. So occupations are just the everyday activities that we do in life. And so that might be a job, but it might be the more basic things like getting dressed in the morning, being able to prepare a meal, being able to eat, those not so glamorous things we all do in the bathroom in the morning. And so anything that occupies your time and is a part of your daily routine, we refer to as occupation. And so occupational therapy assists patients in either developing or regaining their independence and being able to do all of those different life skills.
Okay. And that is different from physical therapy,
Yeah.
obviously.
Yeah. So physical therapy typically focuses on the musculoskeletal system and physical strength and balance and mobility. But sometimes, and especially if you think about older adults, we want them to be as strong and as healthy and as mobile as possible. But a lot of times they're going to be residual limitations, things that they can't do, even though we've done as much as we can to kind of improve their health. And so occupational therapy would work with those individuals, maybe teaching them a different way to do something that they've always done before. Sometimes we introduce things that we call adaptive equipment or different devices to help them to do that. Sometimes we need to modify or change that home environment so that they can stay at home safely. And so things you might think of like grab bars next to toilets or into the shower or specialized seats. Different pieces of adaptive equipment to help someone be able to complete lower body dressing, get on socks and shoes. And so just working with them, using the abilities they have to allow them to continue to do the functional everyday things that they need to be able to do. So we often work alongside and with physical therapy, but we just have a different philosophy and a different focus.
Okay, thank you. What would you describe your philosophy as being?
Yeah, our focus is always on function. And so what are those things that this individual needs to be able to do on a daily basis or a weekly basis? And so often thinking of older adults, it's the things that they want to be able to do in the community. And maybe they need to perform leisure activities in a little bit of a different way. Or maybe it is those more basic household tasks like preparing a meal or doing home management tasks or the real basic things like getting dressed and bathing and toileting. And so our focus is always on how do we allow them to continue to do those everyday activities so they can remain independent, whatever that means. And sometimes independent is in their own home in the community, and sometimes that means keeping them in assisted living so they don't have to move into a nursing home. And sometimes it's working with them in that nursing home to help them to be as independent as possible, to maintain a quality of life or a dignity as they're able to take care of some of their self-care needs.
So I would think it would be important to not do it for them,
Yeah,
right?
yeah,
But to help them
yeah.
learn how to do it themselves.
Yeah, one of the things we really emphasize, and often we'll have students coming in and maybe they've come out of a direct care background where they worked as a CNA or a nurse aide or a rehab tech, and the biggest challenge, we want to help people. That's why we go into the profession. And so it's getting in that mindset of the best way to help them is by allowing them to struggle and provide coaching. And so we teach and we instruct patients for those everyday life activities. We don't do them for that individual. And so, letting them struggle, kind of providing that level of challenge and then teaching them alternative ways to be able to do that independently. The joke always is, we really like you, but we're not going home with you. And so the goal is to set them up to be independent with those skills.
Could you describe for us the steps that a student would need to take to become an occupational therapist?
Yeah. So occupational therapy, there's two different levels of practitioners. There's an occupational therapist, and they're usually the one that goes in, meets that patient initially, sets up a treatment plan with specific goals. They'll contact the physician's office to get approval for that plan, and then they may go forward and treat that patient, work with them on a daily or a weekly basis on moving towards those goals. Right now it's either a master's degree or a clinical doctorate for those occupational therapists. And then there's also a therapy assistant, an occupational therapy assistant, and that's a 2-year associate degree program. And those individuals are the ones that primarily work with the patient on a one-on-one basis. So the OT sets up the treatment plan. The OTA has a chance to work with the patients directly, again, every day or a few times a week, depending on the setting that they're in, on implementing whatever that treatment plan was, and working towards those goals. And then the occupational therapist will generally come in at the end and do the discharge paperwork as well. So either a graduate degree or an associate degree. At the end of both of those programs, you go out and you do what we call field work. And that's a period of supervised practice out in the field in a number of different settings. And so as a student, you learn some skills, and then as a fieldwork student, you have a chance to apply those skills directly. But you have some supervision, you have some help from a more practiced professional. And then the final step is just to pass a national board exam, and then you're cleared to get licensed in whatever state it is that you want to work in.
Great, thank you. I was wondering if you could describe for me this idea of techno-health,
Yeah.
like monitoring someone's blood pressure from afar, for example. Is that being used
It
today?
is, yeah. So I remember the first time I heard about that a few years ago, I really had a hard time in imagining what that could look like or how that could be effective. I work in a home health capacity. I see patients and treat them in their homes in the summer and throughout the school year. And we have a telehealth system. And one of the challenges is, especially working with older adults, they aren't always real comfortable with technology. And so this is a remote monitoring system, but it's pretty low tech. It actually works through the phone line, and it's a unit with a telephone, and it has a blood pressure cuff, an oxygen monitor, a heart rate monitor, and a scale all connected to this device. And you wake up in the morning and you push the big red button that says start, and it walks you through the steps. And so the patient will take their own blood pressure and all of their vital signs, and they'll get on a scale. And what we're looking for there is, have they gained weight, which often will be an indication of heart failure and fluid accumulating. And so this data is automatically sent through the phone line to a nurse that monitors the data. And if the patient's vital signs are outside of the set parameters that the doctor established, then the nurse will contact them and they'll initiate whatever care would be necessary. There's some other higher tech systems that are using like an iPad or a tablet, and they have a camera function built in as well. And so they're able to remotely assist and check in on those patients in maybe a more efficient and less obtrusive way than physically showing up in their home every day. And so those systems are used to kind of supplement or complement that more traditional in-home healthcare.
That's very interesting. I would think that would be helpful in rural areas, maybe?
Absolutely, yeah. And not so much with older adults, but we're seeing that in a lot of rural areas. For example, individuals maybe on the autism spectrum, where the therapists are educating the parents on some strategies to help their children as they develop, and they may do some initial assessment at their center and do some initial in-home training. But then there'll be some check-in visits where the therapists are observing the parent playing and interacting with the child and doing some coaching to help develop that interaction to facilitate development as well. So we're seeing that. We're also seeing using kind of telehealth translators would be another example. And so we have some tablets on rolling stands that will come into the room with you, and the interpreter would remotely observe that interaction and provide translation services as well. And they always have some catchy name that goes with them, some great acronym for that rolling translator that we have.
That's amazing.
Yeah.
Wonderful, thank you. Would you describe a typical day as an occupational therapist? Is there a typical day?
Yeah. So many different settings occupational therapists work in, from neonatal intensive care units with real young children all the way up to the end of life in hospice. We work in hospitals, we work in nursing homes, in schools, in patients' homes. in-home healthcare, in outpatient clinics. So a lot of different settings. Kind of going back to that initial definition, our focus is always on what are those everyday things they need to be able to do that are either difficult or impossible to do or are causing pain, or whatever those barriers are. And we really just look at working with those patients on removing those barriers. In some settings in home health care, we may only see 5 or 6 patients in a given day. In an outpatient clinic, we may see 14 or 15 patients in a day. And hospitals are somewhere in between, 8 to 10 patients a day. And so constantly meeting new people with different challenges and different personalities, and helping them to develop a comfort level. Some of those things that we work on are not real glamorous. They're those things that we do in the bathroom, and it's toileting and bathing. And you need to have an ability to make those individuals feel comfortable working through those daily life activities with a relative stranger. And you have to do that in a short period of time. And then, most of our patients are facing some major life challenges, and so they're not always at their best because they're struggling. And so having an ability to be empathetic and patient and yet motivate and push those patients really to kind of maximize their ability is important as well. So lots of change, a lot of variety. Some of the things I appreciate, we get to be really creative in the solutions that we come up with. There's not a prescribed solution for every problem. And so it's really looking at the circumstance and the patient themselves and the environment you're working in, and figuring out what's going to work. And so I really enjoy that creative problem solving as well.
Is there a typical length of time that most treatment lasts?
Yeah, generally anywhere between about half an hour to 45 minutes would be a typical treatment session. Again, it depends on the setting a little bit. Sometimes in nursing homes, we call it subacute rehab, not the folks that are staying there permanently, but the ones that are there in transition from the hospital back home. They might have a little bit longer, an hour or just over, for a treatment session.
And does Medicare typically cover occupational therapy?
Yeah, so Medicare or Medicaid, private insurances all provide coverage for therapy services, and it's pretty comprehensive coverage. And the goal there, again, is to increase their independence. And so even though there's a cost associated with therapy, long-term there's a cost savings. And so the goal is to get them independent so they're able to function on their own without needing kind of that ongoing sustained assistance.
And can I ask, how did you become interested in this field?
Yeah. So initially I was just interested in a helping profession and something in healthcare, and didn't really know exactly what that looked like. And some of the related professions we were talking about, physical therapy was something that I took a look at as well. And for me, it goes just spending some time volunteering and observing and interacting with therapists in both disciplines, and just feeling myself gravitating towards kind of that creativity I was talking about, the ability to not just do the same set of exercises with every patient with a condition, but really look at what are they needing to do, and what is the environment that they're doing that activity in, and what limitations do they have, and that problem solving. It wasn't as routine or as prescribed, and that was something that was really attractive for me, and I really enjoy.
That's interesting. Thank you so much.
Yeah, my pleasure.
Appreciate it.
Can I ask one more question?
Yeah.
What would you say is gratifying about the work you do?
One of the things I've always enjoyed about occupational therapy is we get to truly enable the patient to do the things that they value, and so we're not pushing an agenda on them. We're helping to empower them to do whatever those things they find valuable and meaningful are. And it can be the most basic thing that for them means they don't need to have a caregiver in the bathroom with them, helping with hygiene after toileting. Again, not a glamorous thing, but something that really makes a big difference in someone's quality of life. And I've just always really enjoyed that challenge.
Thank you.
Nice job. Do you mind